This conference
Okay.
will now be recorded.
AnCan is grateful to for our following sponsors for making the recordings possible. They're Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. And also, we appreciate all the donations that are received from the people who come to the groups. AnCan respectfully notes that it does not accept sponsored promotions, drugs, protocols, devices that are recommended in the discussions are based solely on anecdotal peer experience or clinical evidence that we've read in various publications. AnCan cannot and does not provide medical advice. I encourage you to discuss anything you hear in the sessions with your own medical team. So that will get us started. One more checkup here. Joe Mangione, do you have need some time today?
No, I think I'm good. Thanks, Mark.
Okay, that sounds great. So first in our list is Larry from Central New Jersey. And what we found is using a questionnaire that we've made up, we can better get your story across and make sure that people have the information they need to maybe advise you. And then also get questions that you haven't addressed those. So, Larry, how old are you?
78.
Time out. Larry, you were here last week. This is not the right group for you, man.
No, Rick, you told me last week, since I have been treated, that this is the right group.
No. I told you that if you are recurrent and you've come back, that you came into this group last time.
I thought I was in the active surveillance group.
No, you came in. You came into the active surveillance group, and I told you you have to come back to the recurrent, high-risk, recurrent, advanced group.
Is this not the low and intermediate?
This is low intermediate. You need to be in the high-risk.
Why am I in high risk?
I
don't understand, Rick. I have just been treated. It's in correction at this point. You told me that this was the one I need to. High risk sounds like I'm having a recurrence.
I thought that the reason that you wanted to come in was because you'd been treated and you now are watching, but you don't have a recurrence yet?
No, I don't have a recurrence. I was just treated last month.
Okay, then I stand corrected. Dr. Mark, I'm sorry.
Okay. Sorry about that. Where in Central Jersey are you, Larry?
I'm in Monroe, which is not too far from Princeton.
Oh, okay, great. And when were you first diagnosed?
About 3.5 years ago. I had a PSA of 4.8, 2 lesions, a 3+3, and a 3+4. But my doctor suggested that I go on active surveillance, which I was on until a few months ago.
Okay. And what came up a few months ago that got you to leave active surveillance?
I went from 4.8 GPA to a little over 10. And then once you've approached 10, it was getting to a point that he said, I think it's important. So we had the PSMA test. It looked like everything was still confined. But the recommendation at that point was it should be treated before it gets further. And I went in and I had 28 sessions of proton radiation. And I'm happy to report that a month after that, my PSA went back down to below 4. So that was a 65% decrease in 1 month. So it sounds like what they did was fine, but it did create a little bit of a problem.
And that is what?
Well, I ended up 2 or 3 weeks into it. You know, I was on flomax because obviously the prostate gets, damaged, and so it probably expands. and I started getting a rash. Now, the rash was not at the site of the radiation. It was on my arms, legs, back. And, I thought that, and I've read that flomax could cause this. So once I had completed therapy and a month later, I got off the flomax, but it's now another 4, 5, 6 weeks. And I still have these rashes, and no one has been able to decipher what the cause is. And so my question to the group was, has anyone else experienced this sort of rash throughout their body? And if so, what have they done to exacerbate it? Anybody have any?
I've not had that. Has anybody had any experience with rash from flomax?
I got, well, I don't know, I'm not sure it's from flomax. That was my speculation at the time when I was trying to figure out what was different, and obviously if no one else has had it, then no one else can answer my question.
Are you on any other medications?
Well, I am on some for high blood pressure and, but things I've been on for 10 or 15 years. So unless something is reacting differently from some combination, I don't know. Nothing has changed, but yes, I am on a couple of ones. But again,
do you have any itching from it, or is it a raised lesion?
Yeah, it's a raised lesion that gives me itching. It started out of my back. It seems like my back is relatively clear, but my arms and legs, are still itching. And they've only given me topical medication to control the itching, but nothing to resolve what it is. So I'm now up to a dermatologist to try to put patches on, because she said after taking a biopsy, it's not something I'm ingesting internally, but perhaps something external. But I'll be darned, nothing has changed. Not the clothes I wear, not the places I've been, not the detergent I'm using, so on and so forth. So I was only speculating that it had something to do with the treatments. But if no one else has had it, then I guess I can't get any answers here.
Yeah, and on the biopsy, they didn't think that it was infectious at all.
Obviously not. No, they didn't.
Okay.
And that's all my questions for today.
Okay. Sorry that we don't have a better response for you. That haven't seen that.
So I don't expect more, Mark, but I thank everybody.
Sure
Okay.
sounds like
Eric,
it's time
you wanted
for
to
a
make a
trial
comment.
off flomax.
All right, go ahead, John.
It sounds like it's time for a trial off flomax. I don't know what the dermatologist thinks.
He said he did that.
Yeah, John, I've been off flomax for a good couple of weeks now. And
I didn't hear that part. Oh, very sorry.
I missed that too. Sorry.
My connection's kind of going in and out a little bit.
No problem. But thank you.
Eric may have something smarter to say. He's got his hand up.
No, I had the exact same question, but it looks like you've been off of it for a few weeks and it hasn't dissipated, so hard to say what it is now.
Yeah, well, again, if you guys haven't experienced it, it must be something else. So thank you anyway.
Okay. Let's move on to Jeff. And Jeff, you're in AnCan Rick's neighborhood there. And tell me again, who was it who sent you over?
It was Bill Simons. You can see he had been a part of this group for a few years earlier.
Okay. And how old are you?
51.
51? Okay. And when were you diagnosed?
I was diagnosed October 31st of last year.
What got you to the doc and how did they make the diagnosis?
So I have a brother who's 10 years older than me. And when he was 49, he was diagnosed with prostate cancer. And so that was kind of a sign to me that said, when I turn 49, I need to probably get this looked into. So when I turned 49, my primary care doctor recommended me to a urologist. We started getting some blood tests. They weren't at 49 about February of 2000 3, nothing really to really get upset about or nervous about. I think the PSA was about a 3.1, I believe. And so the urologist said, okay, this is just to let you know, ideally it should be a 0, but at a 3, there's nothing really to worry about. So we got blood tests every 6 months. They were staying about in the 3.1 to 3.5 range. And then about July of last year was the first time I got into a 4. And the urologist said, well, you know, it's still kind of low, but what do you think? And I said, well, I'm glad it's low. And I said, how high does it really go? And he said, get into the teens. I said, I don't want it to get that high if we can avoid it. And he said that there is no way to really know if there is a malignant cancer unless we get a biopsy. So got a biopsy mid-October, and the biopsy showed that there was a malignant cell in the prostate, and I didn't freak out because it was about maybe a half a centimeter. But my urologist said, you know, any malignant cell in there is, you know, we want to keep watching on it. And
Okay, let me go back. Let me go back and get some information first to fill in. Did you do an MRI before the biopsy?
Yes, we did it. Yes, we did an MRI before the biopsy. Let me just check on the date of the MRI. I think it was September 16th. So
Okay.
the September MRI showed that there was a lesion about 0.4 centimeters. And so that was what triggered the need for the biopsy to make sure that it wasn't malignant, or whether it was malignant or not.
And do you know how many cores or how many biopsies they took?
20.
20. And was it transrectal or through the perineum, the space between the rectum and the scrotum?
Transrectal.
Okay. And how many were positive?
Just one sample.
Okay. And do you know the Gleason score?
9.
I'm sorry?
9.
So
4 plus 5.
Okay.
That was kind of a sign that was a pretty aggressive cell there.
Okay. Have you had a second opinion on the pathology?
Yes, I actually am friends with a couple of urologists around the country, so I sent them the pathology report from the biopsy, and they all agreed that with the urologist that probably should not wait on it because it was a Gleason score of 9, and recommended the surgery.
So, and have you done that yet?
Yes, I did the surgery on February 26th.
And what did it show?
The pathology from the surgery showed that there was a malignant tumor. The Gleason score got downgraded to an 8. Also took out the lymph nodes, and no cancer in the lymph nodes. It was all contained in the prostate.
Did they do a PET scan after you had the biopsy before
also? Yes, it was in November. So after the biopsy, the PET scan, actually it was early December. I was trying to find the report from the PET scan, but it also showed that there was nothing in the lymph nodes. It was just in the prostate. Again, I think it had grown to about from 0.4 centimeters. I think it grew about 1/10 of a centimeter from the MRI.
And who are you seeing? Who are the physicians who are directing the care for you?
My physician in Tucson, the urologist in Tucson is Dr. Kenneth Belkoff, and my surgeon was Jenny Myers.
Okay. And what do they have you doing now?
Well, I've just been recovering. It was about 5 weeks of almost doing nothing at home. As you know, the first week just with the catheter, just sitting at home, just letting things heal. And then the catheter came out, and that was an experience that I don't want to ever have to do again. But the first week without the catheter was really rough. It was extremely rough. Just knowing that for pretty much that whole week, I had no control over my flow. It was just, I stand up and there it went. So luckily, my surgeon and my urologist gave me all sorts of tips on taking care of that. And obviously doing the Kegels, but that was for the past 3 weeks. That's been kind of my thing, is just seeing if I can control it better. And day by day, it's been getting better. I can get out of a chair, get out of bed, make it to the bathroom, no problem. I could pretty much do it when I go out in society. Not always guaranteed, but the big part of it is yeah, the whole issue with incontinence is what's really kind of rattling me mentally. Just the whole idea of not being able to completely control the flow. My goal is to be able to, get rid of these adult diapers that I've been wearing, and just go back to normal. I have no idea when that's going to be, but just the fact that, like, yesterday I was out and about and just walking around, and I get the feeling of, oh my gosh, I got to run to the bathroom, and then I run to the bathroom and it's just 3 drops. So, my bladder is telling me that seems to be telling me there's a lot and there's nothing. And sometimes, I don't think there's anything, and then I'm like, whoa, there's a lot. So, I just want to kind of get control over that. And I know it takes time. It could take months to a year. But I guess I'm just one thing. I guess if there's a question I have for everybody is, is there anything to do besides just Kegel exercises to get more under control?
I just wanted to ask first, though, whether the degree of incontinence or the post-op period that you've experienced is kind of what you expected and you were prepared for that.
It was not what I expected, because, again, I guess I took my pre-surgery life for granted. The fact that you can, if you feel an urge, you can say, oh, I can hold this for 5-10 minutes until I get to a bathroom. And knowing that sometimes there is no way that you can control that urge. It just, gravity just takes over. So there's really no, the answer is kind of no to that.
And do they have you on any medicine to try and help control the bladder?
No, and none was recommended to me. Okay. And I didn't really know that there was medicine for this. I mean, I knew about flomax, but I didn't know if that really applied to my situation, if it would help my situation at all.
It can help with the urgency, and it might be something to discuss with the urologist again. But I wanted to ask Rick if you know of any other resources in the Tucson area that Jeff might look into.
I don't really, Jeff, because we don't do a heck of a lot in this low intermediate down here. I have a couple of ideas, but I have to just ask you a personal question, because you look familiar to me, so I just checked. Did you swim for Bobby Davis at U of A?
No, I didn't. I wasn't. I swam at the University of Texas, but I am a swimmer. I mean, that's
right.
kind
Yeah,
of
I saw that. For some reason, I thought you might have swam years ago for Bobby. So
I don't even know who Bobby Davis is, but
he was a U of A coach many years ago.
Okay. No, I didn't swim at the U of A. I moved here in my 30s.
Okay. Well, the first thing I would say to you is, I would ask you is, are you, who's helping you with your Kegels? Are you just doing them yourself, or are you in any sort of therapy?
I've been doing them myself. My surgeon kind of recommended, because I'm an athlete and kind of in shape, that
Right.
I would be able to do them by myself for these first few weeks. I actually have an appointment to see her next week, to hopefully give me the all clear to get back into the swimming pool. And I'm going to kind of have a chat with her to see if maybe we could start thinking about physical therapy to kind of get to the next phase of recovery on this. Yeah, she just said, she told me that probably the only thing I could really do is do Kegel exercises. And I told them I'd been doing them before surgery, and, you know, I'm well aware of how to do them, and they have been working. I guess I've just been kind of stalled at the level of progress for about a week now. Nothing seems to be improving in terms of the level of control. So I have a feeling next week she's probably going to recommend some physical therapy for me.
So what I would suggest is that you get yourself in with a pelvic floor physical therapist as soon as you can, because it's a very specialized type of physical therapy, as you probably know already. And they can work wonders, because we've known guys that they have worked wonders for. I'm going to let Dr. John talk to you a little bit, because he has some good experience in this. But I would say get your ass over to a pelvic floor therapist. I just happened to look up, because they're not easy to find, but there are at least a couple. There's one there is a Desert Healing and Pelvic Health, and then there's another lady who looks like she's somewhere right around TMC. So, you know, I would start. That would be my first thing. Although I don't know how early. Some of the guys who have had surgery may know how early you can start. But that's my first thought. I do think that you know, there may be some medications, but the big issue to recognize is that you've got to allow enough time for healing. So it can really take some time, and you know, we all want to be 100% quickly, but sometimes that doesn't happen, and for some people it doesn't happen for quite a long time. I think we've got some guys you could talk to that would really help. Dr. John is definitely one, and maybe Jimmy. John, if you think maybe Jimmy would be really a good support for you. Those are my first thoughts. I'll keep thinking, but Dr. John, you've got great experience on this.
Remind me again, how many weeks since your surgery?
We are coming up on 6 weeks.
6 weeks, yeah.
Wednesday will be 6 weeks.
I think since you sound a little bit like me in some ways, that you got to watch out for overdoing it. You know, you're probably all ready to do fierce 100% contraction Kegels 150 times a day. You don't have to do that. You're not. First of all, one thing that the physical therapist will show you is the degree of contraction when you do your Kegels. It's not a total 100% degree of contraction. You'll learn how to do it in the optimum way. You don't want to do any damage. You're not even close to healed up from your surgery yet. And just because progress has stopped for 1 week, that's not long enough to get discouraged. And I don't even think it's long enough to consider medications yet. The fact that you've improved already, I think, is a great sign. And I think it's going to take longer, and I want to caution you not to overstrain the muscles, nerves, and blood vessels that have been traumatized so much.
Yeah, everybody around me and people who know me know that I've been very patient these past 6 weeks about everything with the recovery. And this is probably the one part where I feel like, because it's something I could do physically to improve instead of just letting nature and time take care of things, that, yeah, I don't think I'm going all out at it, but I think the athlete in me is just thinking every day is just get a little bit better. And when it doesn't get better, you're like, why isn't it getting better?
Yeah,
And
I quite understand, but I think you could be patient for 6 more weeks.
yeah, I agree. I can, and I have been, and I won't say I'm getting discouraged by it. It's just I didn't know if this was probably the level that I'm going to be at for a while, and if it is, then I'm totally fine with that, and I'm sure eventually then it'll get better. But that was just the question I had: is, kind of, is there kind of a plateau that happens for a while, and if it is, that's totally fine. There's just no documentation out there that kind of says, yeah, expect kind of a, what I'm experiencing. So
Definitely expect what you're experiencing
okay.
and be a little more patient. You're probably due to get your first PSA test this week.
Actually, I'm taking it tomorrow.
Tomorrow, okay.
Yeah.
Well, good luck with that. And don't be discouraged if it hasn't totally bottomed out yet. It's only 6 weeks. Mark and I recently were discussing together how long it takes for PSA to be cleared out of the system, but typically you don't really make any decisions until you've had that 12-week PSA. So that might be another thing to be patient about.
Yeah, my urologist told me not to get high expectations about this first one, but that it should be lower, but just don't expect it to be 0.0.
Yeah.
Jeff, I'd like to ask, I think, Boykin, you had a radical prostatectomy, didn't you, Colonel?
Yes, I did. So I was going to say.
And how long did it take you?
Well, I'm still having some urinary issues, and I had mine in October 2024. So I hear you, Jeff. I think you're pushing too hard. Is my personal thought. After having dealt with this for a couple of years myself, I think it's a matter of, you have to just kind of let the process work, and not all like the folks are saying that you can necessarily make everything work. And I get you about the diapers, and there's a lot of other guys that have that same issue. So it's not the end of the world, but I think the most important thing is that it can be managed, and there are other medicines that your just can prescribe to help with it if you need it. But like Dr. John said, at this point it's too early. They need to work through other things first.
Okay. Ken, at what point did you begin a trial with medication? How far out?
I was about 6 months, because I had to also get salvage radiation. Because I was initially, like you, Jeff, I was diagnosed as a 9, Gleason score 9, and then post-prostatectomy I was a 7. But
So did they
go ahead.
Did they do the radiation right off the bat, just when they found out it was 9 to start and it was planned, or did you see that the PSA hadn't dropped?
The PSA didn't drop enough, and so it was close. It was headed down, but for me, by the 12th week, it was starting to creep back up, and so it's never going to get to the 0.2 that they want. So then they did the radiation, and then that dropped it down to like 0, undetectable for me.
I think that's one of the areas that there is some controversy, although we're leaning in one direction now, in the past, they asked whether if you had a high-risk tumor at surgery, should you go to immediate radiation? And I think the thinking at this point has been that it really doesn't make a difference, and that you can go back into active surveillance as such and monitor your PSA. And if you start to see a rise, then get on top of it early, as opposed to getting treated once a year might not be the way, or checking the PSA once a year might not be, how you want to deal with it.
Yeah, right. I mean, my radiation oncologist, he wouldn't even start any treatments until I was 6 months post.
Yeah.
Post-op. He said I wasn't healed.
I think the common wisdom now is that whether you start at 3 months or whether you start at 9 months, it doesn't make a difference. There was a trial done that supported that. I honestly cannot remember the name of that trial anymore. But I also think Jeff's situation is a very unusual one, and I've seen it before and dealt with it, where you have a gent who has very, very little cancer, but it happens to be high-grade cancer, high-risk cancer. So you've really got to do something. I've worked with guys going back to 2009 yet, where they actually watched it for like a year under the supervision of some really good urologists, urological oncologists, and then had surgery. But the likelihood of you having an issue with so little cancer is probably very different to Colonel Boykin's situation. I just want to assure you, I want to be as reassuring. We want to be as reassuring as we can, Jeff, because you've got enough problems trying to figure out how to deal with this, and you may have ED issues as well. And so, we want to support you. We've got a lot of knowledge in this group and also in the more advanced group, because some of those guys are dealing with longer term incontinence and ED, and there's so much that can be done today. But I
Rick,
also think I was just going to say, I think you've got to give it time. I mean, from what I've seen with surgery, very, very few guys are dry at 30 days. Very, very, very few. There are some, but it's unusual. Mostly you're looking at somewhere in the 90 to 270 day period is when things start to heal up. Go ahead, Dr. Mark.
I was going to say, with your brother, Jeff, having prostate cancer at age 49, and you're being young, it's important that you look at the genetic screening, germline genetic screening. And if you have not yet done that, there is a group called, or a study called the PROMISE study, and their website is prostatecancerpromise.org. And with that, they will do a free germline testing from a cheek swab that they mail to you. I'm wondering, Rick, in this situation, again, with the family history, it probably doesn't pertain outside the germline, but whether you think expanded testing on the somatic testing is appropriate.
Well, first of all, hopefully your urological oncologist, she encouraged you to get a germline test. Did she do that, Jeff?
No, we just went off the fact that my brother had it.
Yeah.
And also when I told my brother that I was diagnosed, he said, oh, did you know your grandfather also died of prostate cancer? Which was something that I never knew, and I think it was kind of a secret. Nobody had, he didn't tell anybody. So, which was probably not a great thing for all of his grandchildren. But
Well,
yeah, nobody ever suggested any kind of
yeah.
genetic thing
Well,
just because I had already knew that I had it in the bloodline.
I mean, I don't know what your relationship is, but you really should be reminding your urologist that she should have told you to get those are the guidelines for somebody like yourself. Those are the guidelines. It isn't a should I, shouldn't I? Those are the guidelines unless you don't want to do it. She could have a shared decision conversation with you, and you may say, look, I just don't want to do it because now I know, but it needed to be discussed. It's in the NCCN guidelines, and it drives us here at AnCan a little crazy because it's basic. It's really basic. And what I'm going to do is I'll put we're
Eric,
not going to
first,
use no, we're not going to use that one, guys. You know that. We have a dedicated link. Which I'm going to put in for you because they track people that we send.
okay.
So I'm going to put that link in for you right now.
While Rick is doing that, to address Mark's question, I think it is not in the guidelines for a non-metastatic person to get somatic testing.
I think it is. Not for somatic, sorry. I'm talking about for germline.
I think Mark was wondering about whether somatic testing on that,
right.
But I don't think it's in the guidelines to do it at this stage.
Right. It's not in it. It isn't called for. Jeff, do you understand? Are you aware of the difference between germline and somatic?
No, I'm not. I was going to ask that anyway. So go ahead and talk about it.
So germline means you inherited. Germline is inherited. It's an inherited mutation. It's something that was passed down to you by one of your parents. And therefore it could have been passed down to a brother. It could have been passed down also to uncles and aunts if it came from your grandfather. The mutation. Okay. And there are certain mutations that generate several different types of cancers, one of which is prostate. So you could have received a mutation that made you at risk. A sister could have received. It's not that the mutations aren't peculiar to either men or women.
Okay.
So that's the one that I was talking to, and I absolutely agree with Dr. John that there isn't a reason for you to do any somatic testing at this point in time. But the germline's really. Do you have kids?
No.
Okay. So, and do you have any other brothers or sisters other than your?
No, just the one brother.
Okay. So there's no reason for you to do this. Was all part of the shared decision making, which could lead you to decide, no, I don't want to do it. The problem is that if you do have a certain mutation, germline, inherited, you're at risk for other cancers, not just prostate cancer. Okay. So if we identify that you're carrying a certain mutation, then we can start monitoring you to make sure we don't get any issues. And since it's only a blood test, a cheek swab, at least with PROMISE, I would suggest you, if it were me, I would do it. If it were me, I would do it. You need to get on the stick with them quickly, though, because this was a trial for 5,000 men, and they're getting very close to the 5,000 mark now. And so if you just follow it through, and don't, when you fill it out, don't have them send anything to the doctor. Have them send everything to you. Otherwise, it'll get more complicated. Now, you can also say to your doc, I'd like to run an inherited mutation test, a germline mutation test, and they can take care of it for you there too. But I don't know what your insurance is, if they charge you, if they wouldn't charge you. At least with this one, it isn't the greatest test, but this is very reputable. It's Johns Hopkins and University of Washington, Fred Hutchinson, and it'll get you what you need to know.
Okay. Thank you, Rick. I appreciate that.
And we like Bill Simon, and you tell him I said hello. And but he's in Phoenix. How do you know him?
No, he's here in Tucson. I saw him last week.
Oh, okay.
Yeah, he's moved down here from Phoenix. He was in Phoenix for a while.
Who knew? Who knew?
So I just wanted to mention that based on having two close relatives and yourself who have prostate cancer, this would put a risk of having a mutation somewhere between 5 and 15%. So it's worth knowing about. And it also opens the door that should there be a recurrence in the future, they might approach it differently, knowing specifics about the mutation that would be found. So I would strongly recommend it, and I'd strongly recommend reconsidering your choice of care when your physician did mention it. It should be a standard part of this, and they should be aware of your family history and take that into consideration. Because two other relatives with the same disease dying from it is an important consideration to be aware of. If that mutation is there, well, it does put someone at high risk. It was found very early in your case, and that's exactly what you want to do. So at least they acted upon the numbers that were there, and it would be great. Hopefully this is over and done for you after you get over the healing phase.
I hope so too. Thanks for that information. I definitely will look into the PROMISE test.
And we do have the link. Rick has that link up in the chat window. You can get in there and click on the gear, I think it is, and that will allow you to save that whole chat window and be able to get that information.
Yeah, you can also double click on that and it'll open up in your browser and you can look at it later. So you don't have to knock yourself. Anybody else have anything they want to say to Jeff about either the incontinence issues? I don't think we have any other. John and Boykin, I think.
I can say a word.
Surgery. Yes, please.
If I may.
Please.
First, thank you for being here. And second, my brother went through the same thing as Jeff 10 years ago. And he is, it took a while, but he's doing quite fine. And, just want to say that. It just took time.
Thanks, JJ. I really appreciate you.
Thank you.
Speaking up on that. I mean, this is the thing, it is time. And I bet you if you came over, and not that we want you to come to the high risk recurrent advanced, but we have more people there who have surgical experience. And there's going to be a bunch who will say, I had big issues, I still have issues. And there's going to be a bunch who say, oh my gosh, I didn't have any problem with the incontinence or the ED. And so you just don't know. You just don't know. But keep coming back and keep asking us.
How's it going, Rick? This is Henry. Hello, everybody.
Hi, Henry. Hello.
Yeah. Hello. Well, I'm gonna chime in. I had surgery at Johns Hopkins in 2023, and it is very prevalent for people to have ED issues and incontinence. For those lucky ones who don't have any issues, you're part of a minority, and it takes quite a while. It's not something that happens 30 days, 60 days, 90 days. It could be months, and that's quite usual. That's not unusual. It's not a quick fix, but it's something that can be managed. You make adjustments, and it does get better, but it's not a overnight process. It doesn't just happen in a short period of time.
Yeah, thanks for that. And yeah, I have ED issues. I'm totally not even thinking about working on that right now. The big thing is to just be able to walk around in public and not have to worry about my plumbing.
Yeah.
But yeah, I mean, again, I know that it takes time, but it, like I said, the documentation never said it gave a wide range. It could be anywhere from 6 weeks to a year. So that was one reason to be here, just to kind of hear some other thoughts and to hear that everybody just said just to be patient. I have truckloads of patients, and I will apply it to this. I guarantee I will.
Jeff, I'm curious if your doc had suggested you speak with a radiation oncologist before and whether you got second opinions.
When I got the second opinions, that was one of the things I was wondering if I would be told, is if the prostatectomy was the only option or the best option. So I talked to somebody who's a board certified urologist in Massachusetts, and he said that radiation wouldn't really be the best option. And I talked to somebody who's a fourth year resident working on urology, and he said basically the patients he's been seeing that are my age, the best thing to do is to have the surgery. So my urologist and I did talk about radiation, and part of it was, the only reason I considered it is so I wouldn't have the issues that I have now. But the big part of it was that if you have the radiation, the big thing that stopped for me was there could be a chance of recurrence. And I was basically in my head, I don't want to have to deal with this again. I only want to have to deal with it once. So that was the kind of the clincher for me to do the surgery. Being 51 when I had the surgery, and he said you'll have a good odds of a quick and easy, somewhat easy recovery. So we all all the people that I had been speaking to just all agreed, just have the surgery, and radiation would be not really the best option.
A lot of what you were told is from the viewpoint of the urologist. And unfortunately, with prostate cancer, there is no one prostate doctor who, there's so much information, medications, diagnostic tests, genetics, surgery, radiation, that you're not going to find one person that handles everything and is aware of the latest research. I think the most important thing, and this behooves all of us, is to go out and we hear about something with this, make sure that they get opinions, not only from urologists, particularly if it's a urologist who's not working in the oncology field or at a NCCN center. They're going to refer to what they learned 5-10 years ago, and may push one treatment over another. I think it's important that people hear on all the treatments before, and that's why I'm spending 2 to 4 hours a day out and about talking to people and getting online just to share this, get those second opinions on the pathology, on treatment options before moving forward. So,
Jeff, do we have your email address?
No, but I'm happy to give it to you if you want.
Because we'll put you on a reminder. We send out a reminder before every meeting, and we'll put you on the reminder for this group. And we have some other very good groups. I'm figuring you're probably not a vet because you were a college athlete.
No, I wasn't.
You weren't. Okay, because we have some great resources for vets, as Boykin will tell you. We have a real good group called Men Speaking Freely, which is which Dr. John, amongst others, moderates. That is to talk about everything and anything except treatment. Although we do talk about incontinence, it's a men-only group, and we do talk about incontinence and ED in that group. So we can sign you up for that. The only thing is, if you don't want to get that reminder anymore, don't unsubscribe, because it'll unsubscribe from everything. And then we have to put you back. Okay. But just go in and change your, you can just go in and change your preferences. But we'll get you signed up, and hopefully we can work with you and help you.
Thank you. I really appreciate that. I just put my email in the chat for you.
Right. Thanks. I see it. And we'll, and again, if you want to speak to other guys, if you let us know, we will connect you to other gents with pleasure. They're most of the time, they're only too happy to share their knowledge and to coach you. I mean, this issue freaks example of being able to go out in public. I mean, they have all kinds of workarounds and little things they do that makes their life much easier. So we'll get with you.
Thank you.
Okay. And there's my email address is right there. Okay.
Okay, up next is Jay. So like to ask you a little bit to share with us some of your background. How old are you now?
Yes, sir. Good afternoon. I'm 65. I just retired in December.
Fantastic. And where do you live?
I live in the West Valley of San Fernando Valley, Los Angeles County, California.
So you're right near me. I'm in Sherman Oaks.
Oh, great. Cool.
And
I see Dr. Gary Bellman is my urologist.
Okay. Oh. And when were you first diagnosed?
Well, if I can give a little background first.
Sure.
So just to start, my brother, I believe he's in his mids, he's about 10 years or so older than me. And at about the same age, he had prostate cancer. I didn't get the exact Gleason score from him, but he just decided, hey, I don't need it anymore. So he had it removed. And I had chimed in earlier, and he said it did take him time, but, you know, he's doing well now. It's been 10 years. Incontinence wise, it's not that bad. So, and then my other brother, he had also, unfortunately, they couldn't get to it because he was overweight. But he didn't die from that. It was other things. But there's a little bit of family history. So in 2019, my PSA was up a little. It was, I think it was like 4 point something, or no, it was 5.9, excuse me. And so they opted to do an MRI, and they did an in-office biopsy, took 14 samples. So that's kind of blind, but they did turn up negative. So then in December, I was doing my physical with my primary doctor, and it shot up to like 6 point something. I don't have the exact number. So he said, yeah, go see your urologist. So I went to Dr. Bellman. We retested my PSA first, and then it was 4.2. Then we did a MRI, and then a guide rectal ultrasonic
fusion
biopsy, I believe.
biopsy?
Yeah, and I guess it's mapped according to the
Right.
MRI.
Okay.
And they targeted the lesions. They found, I believe, two. I still don't quite understand the report, but it was basically adenocarcinoma of the prostate, Gleason score 7, 3+4. Gleason grade 4 is 10% of the tumor. Grade group 2 tumor measures 4.8 millimeters in length. 60% of the core involved by tumor, 1 of 1 core involved. And then there's a lot more notes. One of them specifically states that that inductal spread was noted, 40%, 7.8 millimeter in length, 60% of core involved. Anyway, so his advice was to go see a radiology oncologist at Golden State in Woodland Hills. I went just to find out what it's all about. I haven't made any decisions yet. There's a lot to learn. And he recommended doing the IMRT procedure. I was a little skeptical just because of the way he presented things. I won't go into that right now. And Dr. Bellman did say get a second opinion. So I have an appointment at UCLA Westwood with Dr. Saigal, Saigal. I tried to get Dr. Brisbane, which was mentioned last Wednesday at a meeting by one of the persons on the support group. He was hard to get. Anyway, I'm looking at that. A friend of mine had the HIFU, which generally isn't covered by insurance, but he went ahead and paid for it anyway, and he was happy. It's been over 5 years, so they have a clinical program for it. I'm going to look into that. So I am a vet. I have very good insurance. I worked for Motion Picture for 30 years. So I have the Advantage plan, and I'm pretty well covered, and it's all UCLA. So I guess that's kind of it in a nutshell. I'm getting a second pathology report, second opinion. I had to request it through Dr. Bellman. I didn't ask where it was being sent. I'm going to find that out. I don't know if it's going to Epstein or Hopkins or not. Okay, so and I'm just reaching out everywhere and trying to do my homework.
Okay. It sounds like you've done a great job so far.
Thank you.
I think the second opinion on the pathology is great, but it needs to be with someone who's doing just pathology. So
Okay.
if there's a way to intervene and get it to either Hopkins, Epstein, or Dr. Zhao, I think that would be important, because in your situation, there's a big difference between 3+4 and 4+3. You have a 10% 3+4 and a very small lesion. So you may be a candidate for active surveillance as well.
Mm-hmm.
Question the doctors that you mentioned, Saigal and Brisbane, are they urologists or are they radiation oncologists?
Urologic oncologist.
Okay, so I think that you may wish to speak to one of the radiation oncologists at
So I'm sorry,
UCLA.
I think I skipped that part. I did see a radiation oncologist first.
In Woodland Hills or at UCLA?
Yes, Woodland Hills,
Yeah.
Golden State. But I was going
No,
to ask
you
Dr.
did.
Segal about their program too.
Right. So IMRT is older technology, and the Woodland
Oh,
Hills machine isn't really
that's what I
state of the
thought.
art. So
That's
I
what, yeah.
would see either Dr. Steinberg or Dr.
Steinberg.
Steinberg or Keyshawn at UCLA. But I would push to ask, why am I not a good candidate for active surveillance? You show. I'd probably wait until you get a review on the pathology reading, because if it's really 3 plus 4 and just 10%, active surveillance may be a most appropriate route for you. Other consideration would be the DECIPHER test. And the DECIPHER test speaks to how aggressive
Right.
things may be. The other way to evaluate that is ArteraAI, ArteraAI, and that's going to one, tell you whether there's going to be a benefit from adding ADT into the treatment process and quantitate it, not just, yeah, you should do it or you shouldn't, but say this will reduce the amount risk of having a recurrence by a certain amount. And the other thing it will do, it will predict whether you're a good candidate just for doing active surveillance. And that has been cleared for use in California. Previously, in California and New York, Artera was not available, but that has since changed. Now, I had TULSA Pro, which is offered at UCLA, but any of the focal treatments, are going to require a general anesthesia. They are going to require some discomfort and likely a period of time with a catheter. Not a one of them has any controlled data to show that doing the focal treatment is going to be curative or any more that you will do with the terms of the prostate cancer disease by doing the focal treatment or just doing active surveillance. What focal treatment is known to do and has been shown in studies is that it will delay the time to do definitive treatment. If the disease progresses, it'll be further down the road. But so will active surveillance. And in active surveillance, fewer than 50% ultimately ever go on to definitive treatment. So I think that active surveillance may be something to strongly consider after the second opinion on the path and the Artera and/or DECIPHER test. So those would be things that I might recommend. But other people online here, I don't see any hands up. Jay, do you have any questions?
Dr. Bellman did say his final words were, your options are you can do surgery or you can do the radiation or, the TULSA or the HIFU, which isn't usually covered by insurance. He goes, or some people do nothing. So I guess that was kind of his take, active surveillance.
Well,
So
I wouldn't say
I'm not in a
surveillance.
hurry to make a decision, I think, at this point.
Yeah, you have plenty of time, and active surveillance is not doing nothing. You are doing active surveillance and following on. Just doing nothing would get you in trouble. But
well, I meant when I say do nothing, I mean active surveillance,
not doing active treatment,
not doing any procedures.
The PROTECT study out of England looked at active surveillance. They looked at doing surgery or radiation in people with a small amount of disease confined to the prostate. And what they found in that study is it made no difference no matter what you did. So the other thing is, I don't want to go anecdotal when there is data for some things, but I ended up with epididymal infection and 2 bladder infections and $30,000 out of my pocket before the PET scan became possible. And I learned that I had disease that required radiation anyway. I would not consider any focal treatment unless it was part of a clinical trial, so that we got those results and we're learning from the results. Is it beneficial or not? But I wouldn't look at it more likely to be curable. The other thing is, with your situation, the same as what we said for Jeff, with two brothers who had prostate cancer, you need to go into the chat window and pull up the window or the link for
I
the
copied it
prostate cancer.
already.
Okay, great. And it's easy. It usually takes 2 to 3 weeks. You get the results back. And that's an important thing to know, just to have that in your back pocket. Bill, you had a...
Can I just ask one more question real quick,
Yes.
please? Thank you. So TULSA and HIFU, they're basically kind of the same, just going in through a different area.
Fairly similar, yes.
And basically have the same results and success. Well, we don't know that much about success, I guess, but.
We really don't. We have individual studies, but there's no controlled studies that would allow you to say, well, this is better than that, or this one has fewer side effects, or this one has more side effects. So you don't have that.
Yeah, all I have right now is a friend of mine that we grew up together, had it done. We're the same age, and he's been good for quite a while. And he just went ahead and paid out of pocket.
Well, again, the SBRT nowadays is just 5 treatments, and with the newer methodology,
Which one?
it can be, SBRT is 5 days of radiation. It's a higher dose per, yes?
Oh, I didn't know about that one.
Yeah, SBRT basically is taking the dose. Normal dose at 28 days would be 60 to 70 gray, that being the dose or amount of radiation. With SBRT, they're dropping it down. Usually what they will do is treat the whole gland to 36 to 37 gray, and then bump up the area where they see the lesion to 40 gray. And in the past, what happened is they would beam the energy in, and you would get the same dose across the entire prostate, and it would spill over and get the rectum and bladder. With the newer machines, there's a quick drop off within a millimeter or half a millimeter from the targeted area, and they control for motion in the prostate, and they have smaller margins of normal tissue. And the dose is given over just 5 sessions. So it's a whole lot easier. There's no catheter, and there's
the
no
IMRT, they say you got to go 5 days a week for 9 weeks.
Right, and they have to put metal beads in to check.
They didn't tell me that.
Yeah, they inject metal beads in the prostate, and they do at the beginning. It's not a big deal, but they
But
do.
just that they didn't tell me that, and when I sat with the doctor, the radiology oncologist, all he told me is, "Oh, we do a CT, and you come in, you're here for half an hour, and it's low dose, and it takes 9 weeks, 5 days a week." And when I mentioned that I was going to get a second opinion at UCLA, he kind of was, his attitude was, "Oh, well, they're not that advanced and this and that." And I went, "What?" And I said, "Well, let me think." I go, "Let me think about it, okay?" Because I didn't like when he said that. And I said, "Let me think about it." And then he goes, "Well, what's there to think about?" I'm like, "What is he, a salesman?" He really turned me off.
The answer, Jay, is yes. He's a salesman, and that's the problem.
Thank you. And you did suggest last week, Rick, not to even go there, and I appreciate that.
So one of the studies that I've just been sort of looking at this a little bit, just the last couple of days, today actually was listening. The PACE-B study, which was published last year, I think it was published in the Lancet. It's a British. It was a British trial, and I'll try and find. I just put it the PACE-B study. If you just put in PACE-B prostate cancer, the problem is I'm getting I'm getting the PDF on it, and what I really want is the I want a URL for you. This
Okay.
this compared it compared SBRT, which is stereotactic body radiation therapy, which is 4 or 5 doses. There are some people who do 5 is approved. There are some doctors who will do it in 4, especially those doctors who are in academic settings, because they don't need to bill the 5th dose, and there's some question as to what extent you need that 5th dose, but you do need 4. They compared that to regular IMRT, which is what they offered you, which is over 9 weeks. And then the third thing they compared it to was a more intensified over, I think, 7 weeks or something like that. And what they determined in this study, the PACE-B study, was that the SBRT was non-inferior. So non-inferior is medical language for doesn't make a difference. So it's no worse or is no worse. It's Dr. Mark is shaking his head, but for you and me, that's what non-inferior means. It means that the results that they were trying to measure were no worse with the SBRT than they were with the other protocols that they measured. I'll let Mark rebut me.
So what I was going to
Hold
say.
on a minute. I'll let Mark rebut me afterwards.
Okay.
But let me just say, the bottom line is that we think today that the SBRT is just it is a really good alternative, and you can get it done in 4 or 5 days, and you can get that done at UCLA. There may even be better technology, which Mark will tell you, at UCLA. But either way, you don't really need to do more than 4 or 5 sessions. Go ahead, Mark.
Okay. So one of the problems is doing research is incredibly expensive. And I don't remember all my statistics courses, but the number of patients you need to show that one treatment is better than another with 95% certainty, which is the way the studies are designed, you need a whole lot more patients in the study than if you want to show that these two are just about as good as each other. So when you come up with a study that shows non-inferiority, in order to get approval, all I have to show is we're just as good as another treatment that is improved. It doesn't mean that it might not be better. It means that they just haven't done the study to show that. I think we do know in radiation now, you want to cut the margins of normal tissue. Prostate moves when we breathe, when we pass gas, as our bladder fills. The prostate is going to move around a little bit. And if you're doing proton, they'll take one CT at the beginning and they'll look at these little metal beads that they put in to see that things are lined up properly. Unfortunately, during the course of treatment, when the beam is on, things can move around. So they add on a fluff margin around the outside. CTV, or clinical treatment volume, is the area of the tumor that you want to treat. And planned treatment volume includes anywhere from 3 to 5 millimeters added for safety, just in case things move around. The problem is that PTV, or planned treatment volume, or extra margin, is just radiating normal tissue outside the prostate. And that's going to get us in trouble with the radiation. That's going to get the bladder and the rectum. So if you look at newer systems, the one in this area is going to be Meridian at UCLA, at MD Anderson, It's Electa Unity machine, and those are going to cut the margins. Now, they are guided, and 8 times a second, they're looking to see if things move around, and they turn off the beam or adjust the field if things move. There's another system called CyberKnife S7. We've all heard of the CyberKnife. That allows them to reduce the margins as well. But CyberKnife is CT, and it does involve that procedure where they put the little beads in. Those are not necessary with the MRI. And with the MRI, they also actually see where the tumor is. So it better allows them to paint the tumor dose. So in mine, I got 1 dose to seminal vesicles. I got a higher dose to the tumor. Then surrounding it, they dropped it down a little bit. And then the rest of the prostate got 36. So it's like a paint by number for the radiation oncologist that you certainly don't have with any of the other focal treatments. Bill, you've been patiently
Thank you
waiting.
so much.
Just a quick comment. Jay, your situation sounds like mine, except I'm about 4 years ahead of you. I was in active surveillance for 4 years. What sort of kicked me out of active surveillance was a high risk DECIPHER score. So I would strongly encourage you to get that, to ensure that there's not something sort of lurking in there that you wouldn't otherwise know about, because I was a sort of standard Gleason 3 + 3 = 6, but PSA kept going up. There were a number of things that were sort of confounding us till we got the DECIPHER. So I'd encourage you to get it.
Thank you, because that's the part I'm not sure how exactly aggressive it is.
Yeah, I'm glad I know now.
Thank you, Bill.
It would have been
Are
great
you doing okay?
3 years ago.
Are
Yeah,
you doing okay?
I'm hanging in there. Thank
Good.
you.
Good. Thank you, Doctor. Rick?
Any other comments here for Jay? Jay, do you have any more questions for anybody in the group?
No, thank you very much. You fulfilled my questions for now. I appreciate you guys.
Okay.
Very helpful.
I just wanted to add on the PACE study, Rick. Again, that was done with CT guided machines.
Yeah.
And we know from the Mirage study with the reduced margins, you had a 40 to 60% reduction in early side effects and the side effects at 2 years. So the margins matter, the adaptive radiation therapy and the gating matter a whole lot less. But the machines now are a lot more precise than the previous ones they used for IMRT. There's also some recent work that suggests that the higher dose rate is going to do a better job killing cells. While that may happen in a lab, it hasn't really translated into clinical trials that show better outcomes yet, but they're certainly hoping.
Yeah, the only thing I would say for Jay's benefit is, you and I basically agreed on this, that SBRT is probably better than IMRT, and that some of these other technologies that you're referring to with the better margins are even better than a lot of the SBRT machines. And the place to get the best equipment, any doc who tells you that they don't have better equipment at UCLA should be struck off, to be honest. It's fine to say they have different equipment, but to say that it's no better than what he's offering, which is 9 weeks, is disgraceful. It's disgraceful. And I tell any radon to his face, you can't mislead patients like that. So if I'm saying to you, if I say, take a look at that PACE B abstract, and the SBRT is no worse than the other stuff, you can be assured that if you get treated at UCLA, you're going to get even better treatment than what you're reading about in the PACE B abstract.
Thank you.
Okay, let's see. Next on the list here is Tim.
Yes, I just wanted to give an update on some of the things been going on. For those who don't know, I had SBRT. I was a 3+4 in May last year, and my SBRT treatments ended on October 30th, 2024. And I've been following a lot of the recommendations that were put out by this group, namely PROSTOX, DECIPHER, PROMISE study, and the grid report from DECIPHER. And I did get my grid report recently, and I think I got the impression I was the only one who has ever requested the grid report from my urologist organization, because they were kind of aloof about it. But I did contact DECIPHER, and they were very easy to deal with. And I ended up getting my grid results. And there were a lot of questions. It was an 8-page report. And I requested some interpretation and explanation of it from DECIPHER, and they were very quick to have a pathologist call me, Dr. Amy Waba, and we went over it by page, and they were very easy to deal with. And I would recommend that if you got a DECIPHER test, that you get your grid report too. And that was basically the point of what I wanted to make tonight.
What good service.
Yes.
Tim, I wanted to ask you about that, because did you get the report before you were on the phone with these people? And how did you feel, or what did you understand when you got the report? Did you find yourself like, oh my God, I don't have a clue what any of this means?
It wasn't that bad. I didn't say I don't have a clue, but because, with the internet now, you can look up a lot of terminology. But I still wanted a little bit more personalized attention, and they willingly gave it to me quickly. And it was good to know that they had good follow-up.
When I spoke with them, they kind of dissuaded our suggesting it. One, because the idea was they would gather this information, this extended panel, and they do that on everybody. It's just that they don't report it back, because they feel like first they get the calls from the patients and they get the calls from the doctors. And across it says this is for research purposes only. So I think it was unclear how the average urologist who might order a DECIPHER test was going to be left with this test that they really don't understand.
Yeah. Yes,
Dr. John, would you like to comment on that?
Well, I was just commenting to Rick in the chat that back when I was learning how to read grid reports, I was working with one of our members over his grid report, and made a tremendous number of attempts to get through to the doctors at what's DECIPHER's company?
Verisight.
Yes, Verisight. And just had a really hard time getting through. So I was very pleased that you actually got a pathologist on the phone that was willing to talk to you and not just your urologist.
And the other thing, Tim, is I was standing next to Dr. John when we spoke to Verisight. I was not there when Dr. Mark went to speak with them, but they told me that he'd been by. And just exactly what Mark said, we sort of got the impression that these were all just intended for research, and they weren't that thrilled that we were talking to patients about them. but they
Yeah.
they would tolerate us. I mean, it sounds like maybe in the last month or 2 months that the word's been getting out, and maybe they've changed their opinion. I don't know. It might be worth a call to them, Mark or John,
Well,
again, and see where they
they
are.
they do have a good video on the website that explains some of the things that they look at in this report. Again, a lot of the stuff, we have something, we know what it means, but we don't have the evidence that says, now that we know this information, if we change what we do, are we going to get better outcomes? Is this an effective tool? Or is it just really nice to have the information and it makes us either feel more comfortable with our decisions or less comfortable? But in terms of guiding treatment, they really don't feel that they have any information that it should be used as a treatment guide.
In fact, if you do talk to anyone at Verisight, you should start by promising them you will not use grid information to make any treatment decisions. Regular DECIPHER, fine. Not grid.
Well, at no time did they make me feel like I was bothering them. So
That's
it went
great.
well.
Super. Any other comments for Tim? Did you have any problems with the docs when you ordered it or asking them to order it? Or did they get a copy of the grid report as well and have any comments for you?
Technically, the urologist had to order it. And when I got them to finally do that, it went quickly, and they haven't commented on it other than that they've received it. They didn't want to they've never shown any interest in getting involved or explaining it. So I went through Verisight, DECIPHER.
Okay. Let's go on, Bill. You had your hand up, and then you also asked for some time in the beginning. So you're up.
Just real quick, I had a similar experience with my urologist in the grid report. They resisted at first, then they ordered it. And when they got it, they were very pointed in terms of calling and telling me that it would not be helpful in any way to determine next steps for me. So anyhow, yeah, I met with Dr. Adam Keibel and Dr. D'Amico at Dana-Farber last week. Again, Rick, thanks for the referral through Dr. Van Allen. It was sort of the usual that you would expect in terms of, the upsides and downsides of each treatment. But at the end of the day, they were waiting on the ArteraAI results, which Mark, you recommended last week or 2 weeks ago, I think. And those should be in later this week. Dr. D'Amico said, if in fact that validates what we have seen, through DECIPHER, then, the appropriate way to proceed would be, ADT, probably six months to 2 years of ADT, somewhere in there. And then probably 6 weeks of radiation. If it came back as, not the ADT not being particularly helpful, then, it could be sort of a choice between surgery and radiation. So we'll wait and see what the ArteraAI comes back with and says, and, we'll go from there, but obviously I'll keep you guys posted. Any comments or anything that I'm missing or anything? Mark, I saw a funny look on your face. Maybe that was...
Well, I was curious as to what got them thinking that long-term IMRT or surgery with the 3+4? Was it specifically the presence of the PNI, perineural invasion, or what was the?
They weren't particularly concerned about the perineural invasion. What they're very concerned about is the DECIPHER coming in at 0.91.
Okay.
So,
and I think there is good information that DECIPHER may trump Gleason scores in terms of the outcomes.
yeah, they were most concerned about the DECIPHER, the Gleason 3+4, which they had had a second opinion on the biopsies. It was previously 3+3. So that was the one that they were sort of quite concerned about. So great news is I'm in a good place. I'm in the good place. I am in the right place with the right care. Many thanks again, Rick, to you and the AnCan team and Dr. Van Allen.
Super.
I'll be sure to let Ellie know that you're very appreciative. Two things that, excuse me for butting in here, John, but I just want to follow up directly on this. Did you share that grid report with the doctors at Dana-Farber?
No, but that's going to happen.
Okay. Well, I suspect they're going to find a lot more use from it than your other urologists did. And I think they'll probably be very grateful for you to share it with them. And I definitely think that will be helpful for you. I'd love to hear their opinion, especially people both as reputable, in particular D'Amico, that they'll make something out of it. The only thing that bothers me slightly is why they're still talking to you, why D'Amico's talking to you about 6 weeks of IMRT. I mean, why he's not talking to you about SBRT or one of these other types of, radiation because he's well aware of it. I mean, you may need treatment outside of the gland to the bed. You may need treatment to the nodes if they have any concerns, but if not, they should be able to treat you in 4 or 5 sessions.
Yeah, I brought that up, and he said I'm concerned based on not the biopsy but everything else that I'm seeing that the cancer has spread.
Yeah,
and he sort of said, based on the look at everything that I'm seeing here, despite the fact that that the biopsy is a 3+4, he said there's a chance that it's an 8 or 9.
Yeah. Well,
we want to go get the lymph nodes.
Right. Okay. So what he said when he said 6 weeks, what he's looking at is treating the gland and treating a wider area. So then that makes 100% sense. That's the clarification I was hoping you would provide. So
thanks for prompting. Appreciate it, Rick.
Okay, John S.
Yeah, Tim, I just wanted to follow up, or Mark or Rick. The grid score, what benefit is it going to bring to us after, I had low risk DECIPHER, had the MRI guided SBRT 5 months out, relatively no side effects. So, Tim, what insight or value did you gain from it, or anybody? How helpful is it?
Well, I would think in your situation at this point, it's not going to provide additional information that will change anything. What you do.
Because, Tim, you're in the same boat, right? Did it provide what additional value did it, or?
Yeah, it gets into mutations, and looking at it right now. Um, it talks about androgen receptor activity, how likely my body will react to androgen deprivation therapy. It talks about cell cycle progressions for tumors, and it gives you a rating score for low risk or high risk. It talks about risk of upgrading the tumor, low versus high, risk of upstaging the tumor, low versus high. In other words, how likely it is to travel to the seminal vesicles. I think it's worth your effort.
Or scary.
And that's
Well,
just page and that's just page one.
Right. Okay.
yeah, I mean, this is really tricky. I'm sorry that Dr. John had to leave because this is kind of his area of anxiety management. That he's a Dr. Mark is a surgeon. Dr. John is a psychiatrist, and so much of what we deal with in working with prostate cancer and having to make decisions is anxiety management. Now, there are some people who deal with that well and they want more information. There are others who really don't. And will it make a difference to you at this point in time, John? It won't. On the other hand, God forbid you have your disease comes back a little bit, it could have some very, very significant information. Whether you'll be able to get that grid report when you need it, I don't know. So if you ask for it now, you have it, even if you don't look at it. But is it going to change where you are right now? Probably not at all. It might have changed some of your decision making before you had the treatment. So, my feeling is, well, yeah, paper your file if you like, but I don't
I think
know.
it also depends.
Come on, what do you say?
I think it depends on whether you have a physician and the type of relationship. Um, what we heard from Bill made a lot of sense. He's got information. When I walked in a room with a patient, as long as it wasn't a stack of old medical records that was 6 or 8 inches high, I wanted every piece of information I could get. And if I didn't understand it, it meant that, I don't have an answer for you right away, but I'm going to have to go back and do some research and try and understand this better. If you don't have that, and you're one who gets tied up, tying yourself in knots based on the decision making process, I think it's going to only hurt. At this point, following the PSA, if the PSA rises, it's there. Once you had your DECIPHER done, they just press a button to get this out. They don't have to do anything else. So, I mean, if um, at some point in the future my PSA rises, I can ask them if that was the same way, press the grid button and get that report, because I know my doc will sit down and talk to me and be interested in seeing the result. If you don't have that relationship and you don't remember the words at top that say this is for research only, I think it's of limited value.
All right. Thanks.
Yeah. Okay. James and Emily. Did they take off? I think it looks like they may have taken off. Um, wow, that gets us. Jay, you had your hand up.
Yeah, just chiming back in real quick. One question that I forgot to ask about PET scan. my primary doctor, when he did a little consult with me about all this, just to help give me direction. And he said that when I go to see my UCLA doctor, the urologic oncologist, Dr. Seigel, on the 23rd, that they may most likely check other parts of my body. Is that what a PET scan is? And just, I also mentioned in the beginning that I am a veteran. Rick had mentioned there's other places to reach out for veterans. That was all.
Okay, well, I'll cover the PET scan one and let Rick or Boykin cover the veterans activities on AnCan.
Thank you.
But the PET scan is from the neck down to about the knee. I have seen cases where there's disease even below the knee with this. But the higher the PSA value, the more likely that a lesion will show up. It can be the dyes, most of the tracers are excreted through the bladder. So the bladder may be filling up and making it harder to get a clear view of the rest of the pelvis. But it is looking for spread anywhere. But a positive PSA, PSMA PET, you don't want to find it, but that's the helpful thing. If you find something and there are very few lesions, they can pick them off one at a time. On the other hand, a negative PET scan doesn't mean you don't have this. When we're looking for biochemical recurrence, it's roughly 50% of the time. The PET scan will pick up disease that may not have been seen otherwise. So it's important that when we look at the PSMA PET, we don't look at it and say, well, I don't have any cancer that's spread. It's better to say, well, they couldn't find any evidence that it has spread. So that's what I was going to say about that. Go ahead, Rick or Boykin.
Thank you.
I'm going to defer to Boykin to the Colonel because he's a peer and he attends that group and he can talk to Jay peer to peer. Go ahead, Boykin.
Absolutely. Okay. Happy to come in. So I don't know how well you guys can see me. I have a camera issue right now, but the veterans group, this month, normally I think meets on the first and third Tuesdays of the month.
You're kind of breaking up vocally on my end.
Okay.
Can you put a link in the chat?
Yeah, I will. I'll put some stuff in the chat for you, but I'm in the hotel room.
Actually, I see one there now from Rick.
Yeah, from Rick. Okay. So the focus is with that one is to focus on how to make sure that you're getting all your veterans benefits. And
okay.
Yeah. And so Jim Marshall runs that. Captain Jim is what we call him. And he does a great job, and he's really an expert. You don't really need a BSO. You can use one, but you can also use Captain Jim, who makes sure that you can walk to and he teaches you how to prepare your own package. And we have quite a following of guys in there that just come because there's always complications. There's always and the different ways you can file a claim, like secondary conditions. A lot of people aren't aware that they're just thinking one thing. And when you talk with Captain Jim, he has a way of helping you connect the dots to see those things. The other thing is that the laws and the rules and procedures, those kind of things, those kind of regulations that we call them, they're constantly changing. And Captain Jim is a fanatic about staying up with all that stuff. So he is actually your best source of information to find out kind of what's current and what's going on and what's changing, and then helps you walk through and see how it matters to you.
Thank you, sir.
Yeah, and the other thing, Jay, is that for some people who may not have strong enough private insurance outside, there are ways to get things done through the VA that you might not necessarily be aware of, especially in Los Angeles. Probably one of the best VAs in the whole country is West LA. I mean, they're staffed by loads of people, docs, male, female, from UCLA. There's all kinds of stuff you can get there. If you're getting grief about getting a PSMA PET, you can get your PSMA PET. We encourage a lot of our vets to be dual enrolled. So even if you think you've got the best insurance, if you are not enrolled at the VA, we still say get enrolled, because if you find you need it, don't be stepping through all those hurdles and the bureaucracy when you need it. Do it ahead of time so the VA is still there for you. In your situation where you are is you probably won't need them. We're hoping you don't need them, but we never know. The other thing with Captain Jim is he'll find benefits for you that you never thought you could get. And I mean, he's unbelievable. I mean, he's unbelievable. He knows the ins and the outs and the alphabet soup. And I mean, I'm certainly not a vet, but he is amazing. And he makes a difference to everybody, from privates to generals. I mean, we got generals who never bothered. They had TRICARE. They never bothered to dual enroll with the VA, and now because they're dual enroll with the VA, they're getting their drugs cheaper than they were getting them on TRICARE. So that's why we say, and you have to be patient. And now the other thing I want to say is, starting the 22nd, I believe, of this month, we are delighted to be starting a new group. We mentioned before we have a men speaking freely group, which is for men only. We have a women speaking freely group that is for women only. And we are starting a new group at the end of this month called Vets Speaking Freely, men and women who served and who want to talk about anything that is on their mind. But we're not talking about treatment. We're not talking about benefits. We're not talking about we're not talking about your health care at the VA. It's really a group for those vets who have been coming and they don't find a space to talk about a lot of issues that we know many vets have from their years of service. And we're really thrilled to be able to moderate, to provide that group. Colonel Boykin is going to be one of the moderators. Dr. John, who spent his whole working career, he's not a peer, but he spent his working career at the VA, or about half of it. The other half was academic. He's not going to be a moderator per se, because he really can't be, because he's not a peer, but he's going to be in that group to help us out. And then we've got Bill Franklin, who's our president, our AnCan president, who is also going to moderate. He's definitely a peer. He was in Desert Storm and goodness knows what else. So we're really excited. We're really excited about that group. And I see James and Emily came back. Dr. Mark.
Yes, we did. Now we got bumped off, and we have no idea why.
So you're up.
Okay, we're up.
You're up. How are things going?
Sounds like there's some really good doctors in California. Yeah. Better than their politicians, huh? So. I had to throw
Is this the people with the cat's picture?
Yeah.
Yes.
Well, it used to be.
I'm glad you guys are back.
Okay.
Did
I'm
we
sure
go over
last
your
week,
full story last week?
yeah, story last week, diagnosed with prostate cancer, had a biopsy done in December. 5 out of 12 cores came back 3+4, every one of them. 1 on the left, 4 on the right. DECIPHER was very low, 0.19. And I went back and I thought I had an MRI, but I had a PET scan. I think it was with contrast. They do them with contrast?
Yes, a tracer. Yes.
Contrast. But I had not had an MRI recently before my diagnosis.
Y'all asked last week.
Yeah, y'all asked me if I had, and I went back and I thought I had, but it was for something else.
So there was
anyway,
no MRI prior to the biopsy?
No MRI. Well, when I talked to my urologist, he said it was not a guided MRI. So I'm not sure exactly what that means.
Y'all wanted him to ask if he had one, was it I'd have to find my notes.
MRI fusion.
MRI fusion, okay.
Well, he didn't even have one because he called the office, he left the message in the portal, and all he could find was one from 2023. So I think it's safe to say there's been no MRI. I think our question is, does he still need one, and do we trust his current urologist to order it because he's not the one that would be doing it? What's y'all's recommendation on that?
So let me go back here. When was this biopsy done that found the 5 of 12, 3+4s?
That was done on. Well, the report came out on December the 23rd. So
I think he had it done on December 11th.
December the 11th
of last year.
Okay. And they had no MRI with that?
No.
Do you have did you have any treatment or anything done as a result of that?
The PET scan.
Okay, and that showed no spread. Okay.
Right.
So essentially the way I would look at that is you have no diagnosis yet. Unfortunately, an MRI ought to be done to find out, are there any areas that look more aggressive? Because you really don't know if the biopsies were done in the areas that were most aggressive.
Okay.
So one, an MRI ought to be done, and 2, it ought to be done by a team of people who are going to provide you with care that is standard modern care, where they would look at the MRI before doing the biopsy and doing an MRI fusion biopsy. So while it's great that you had a 3+4, I'd also want to send that slides off to the doctors that we mentioned, either Johns Hopkins, Ming Zhao, or Jonathan Epstein, to review and make sure it's truly a 3+4, and then the percent. Now, and I know, Rick, you may argue with me on this, and you brought up a good point last week. If you send the biopsy off, and then you find that there's some lesions that might not have been biopsied with the MRI since it wasn't a fusion biopsy, maybe you wait until you do another biopsy. And I don't know how to approach that. It's one of the things that I've struggled with in terms of people who get a biopsy and it doesn't look so bad, and it was not an MRI guided biopsy. It was a pin the tail on the donkey biopsy.
Right. Okay.
And unfortunately, it wasn't the tail on the donkey who did the biopsy.
Yeah, my last MRI was done in June of 23. So, all right. So I'll definitely reach out to him and ask him to go ahead and order an MRI.
But
would that be suggested?
Well, I don't know how to tell. I mean, if there's certainly a 4 or 5 lesion on there, a more severe lesion, then I might want to look. There are other tests. Since you had a low DECIPHER in this area, you might look at a test called ExoDX.
I did.
And what did that show?
That showed it came back extremely high, like around 54.
Oh, okay.
But since then, they haven't really mentioned anything about that, which I thought was kind of interesting. I did order the PROMISE test, by the way.
Yeah. Who didn't mention anything about the ExoDX?
My urologist and his PA.
I mean,
well, I think you've got two pieces of evidence. You have two pieces of evidence that you should retire them. The ExoDX, normally 19 is a level where if you don't see anything on MRI and the level is 19, there's a great likelihood that you will have significant treatable disease. They didn't find disease that necessarily is treatable. So I think you may need to find a new team to do an MRI and perhaps a fusion biopsy to see what's going on. I don't know that it's safe to rely on this 3+4 as the gospel. I don't know. What are your thoughts, Rick?
Yeah, I mean, I would start over, James and Emily. I really would. I think there's too many bad pointers for these people. They didn't do an MRI. They didn't do a fusion biopsy. They really haven't. They've been inappropriate in terms of how they responded to you, and it's like there's nothing else that you should do except get treatment. And right now, these are not people that you want to be continuing with. I certainly wouldn't ask them to order an MRI fusion. I wouldn't even trust them to do the for them to do that biopsy. If they don't know to order a MRI in the first place before doing a biopsy, maybe they don't even know how to lay the maps over each other. I mean, I as I said to you last time, we really don't know where we are. We may have a situation where you're great for active surveillance and you don't have to do any treatment. We may have a situation where you need treatment, but what we've got to do is we've got to get you to somebody that we can rely on. And probably
in the area. You said that's the part of the problem, right?
Well, there isn't anybody in Austin
or Round Rock or any of those other towns, right?
No, you're going to have to go to either San Antonio or Houston, or Dallas, which is even further. But basically, you're going to be looking at San Antonio or Houston, and I wouldn't be messing around. I mean, you go to UTSA or go to MD Anderson. If you want to go to a doc, a urologist related to Houston Methodist, I can get your name. But I would say for where you're at, probably, I mean, Hugh Idstein likes his doc, his urologist at Houston Methodist. I mean, that would be a really good person for you to see. He's very comfortable with him, and Hugh has 3+4. So come into the group on Wednesday night and find out who it is and see if Hugh can make a call. A lot of times with our AnCan guys, they'll call up their docs, and the docs are only too happy to help someone else out.
Okay. So also you mentioned UTSA in San Antonio. Do you have a name?
I could get you a name. I don't have one right now, but I know the names I have at UTSA are really for the genitourinary medical oncologists. I'd need to do a little bit of research for you, or somebody would need to do a little bit of research for you to find out who's best for sort of the active surveillance. But you know, if it's 6 of one and half a dozen of the other, and it's about the same distance, isn't it, from Austin to San Antonio as it is to Houston?
It's a little longer to Houston, you know.
It's twice as long to go to Houston and to go to Dallas. I have a sister in Dallas and one in San Antonio, so those would be my preferred options if I'm going with him.
Okay, so in other words, you'd rather go to
San Antonio or Dallas.
Okay. I'd have to do some work to. We'd have to do some work to find out. See, the problem is I don't want to send you to any urologist. I want to send you to a urological oncologist, a surgeon who we know looks kindly on active surveillance. That's the issue.
Okay. Because, I've heard a lot tonight about, what is it, SBRT with the 5-day treatment versus the 28-day.
Right.
Does anyone know if there's any difference between proton therapy and photon therapy?
Go ahead, Dr. Mark.
Yes. Well, I'll just start. Proton is a hype. Standard proton therapy. Eric, you're smiling.
Proton is a hype?
Proton.
Oh,
yes.
Proton is a hype. Okay.
Proton. When I was in Atlanta, went to Emory there, and they tried to sell me on 45 proton treatments versus 5 SBRT. Proton is older technology. They talk about the Bragg effect, where the bulk of the energy is dropped at one spot and then the energy falls off. The problem is that there's no connection to deal with movement. So if things are moving, and the prostate does move, the entire energy in the beam may be dropped off where you don't want it. The proton sets up with larger margins than modern SBRT. It would be in Houston, it would be the Electa machine, but the margins are smaller, so you're radiating less normal tissue around the bladder and the rectum. There was a study called Partiquol, Partiquiqol, that was published maybe a month, 2 months ago, that compared older SBRT with, older IMRT with proton and photon, and they found no difference in side effects and no difference in outcome. The newer SBRT methods potentially are more effective and have no greater risk and have smaller margins. So why do a treatment that they aim at 45 treatments versus one that there's normal 5? Dr. Rossi in San Diego spoke at PCRI 2 years back, and he does more proton than anybody. He has a big proton center, and he won't do SBRT because he feels there are too many skin burns. All the energy from proton comes in through 2 beams versus CyberKnife, which has really an infinite angles as the beam moves or the machine moves while the beam is on. The MRI has 15 beams, so you're dividing the energy over a lot more paths. So the risk to the tissue is no less. A lot of good theories about proton, just hasn't been any studies that show. Well, there have been studies, and those studies show no difference at all. So I certainly feel like you need to pursue that.
So you would recommend staying, if you decide to go with radiation, to go with photon?
Yeah, I mean, I see no
There's more data
um,
on. Okay.
no reason to look elsewhere. But I don't. I mean, there are at least 12 different photon systems, and um, I do think that the MRI Linac, which allow, or CyberKnife S7, which allow for smaller margins, may be a better approach. Eric, you had your hand up.
Yes, thank you. Yeah, I toured that Proton Center in Atlanta. Had a very cool behind the scenes tour, and it was all about locking you into that table to make sure you didn't move at all. That was very critical. It was interesting. But for James and Emily, I have a question. What has your PSA trend been lately? I'm just curious.
Well, the last PSA I had was 6.5, and that went
6.65.
6.65, and that went up from like 5.5 6 months prior.
Okay.
And then it was at 4, and my DRE always showed I didn't have any nodules, and everything was soft, and
it was normal size.
It was normal sized, and when they did say that, we met with a surgeon and we met with a radiation oncologist in Austin, and the radiation oncologist said to us, he goes, "Yeah, MD Anderson is going to be bringing a satellite down to Austin, but they're not going to bring the proton."
No, they're not going to bring the photon.
Well, they do push.
They
do push proton there.
Yeah, they're going to leave the proton there. And I said, "Well, why is that?" He said, "Well, they didn't want to take away from their business." And I'm like, "Okay." And he said,
"Isn't the proton the longer treatment?"
No. They're both can be SBRT.
Oh, they can?
No, well, it depends. Not everybody is doing SBRT with proton, and they tend to push it just because there may be limited indications, so they want to use the machine. But there are more skin burns with it, and there really isn't the data and experience with SBRT with proton the same extent there is with photon.
When we talked to the surgeon, and he goes, he even said, after looking at my numbers and everything, which I'm starting to question now, he said, "You're probably not going to die of prostate cancer," And so
the urologist said the same thing.
Yeah, and they both said it, but they said the main thing, he goes, if you're going to get radiation therapy, I said, "Would you recommend the 5 or 28 day?" And he said, "I'd recommend the 28 day. And I said, "Why?" He said, because as a surgeon, he said, if they're off just a little bit with that much radiation, you're giving like 5 times more radiation. He said, you can cause, he said, "I've just seen a lot of scarring and things that I've had to deal with that was due to the shorter course of therapy versus the longer course."
Well, again, the newer machines, that's not true. Okay. And there is a test called PROSTOX, which is a genetic screen, a cheek swab, that allows them to suggest whether the 5-day treatment, you may be at greater risk of long-term side effects from it. That's about 5 to 7% that have a positive PROSTOX test, in which case they're recommending 20 sessions rather than 5. But there's better killing and just a better response with the SBRT. And I think most people are moving to that. When you're talking to a urologist about radiation therapy, you're probably hearing something that maybe came out of a textbook when they were training, and it may be 10 to 15 years older. So I'm not sure that, again, you're getting the best information on that. Eric, I'm sorry, I interrupted you.
One more follow-up question was, you said you had an MRI, but it was way before all this. Can you say what it was for, and would it be helpful? And would it be helpful to get scans or the CD or any of that for a radiologist to look at?
Not if it wasn't for prostate. A
Yeah, I didn't know what
non-prostate pelvic scan, a scan of your hip or your back isn't going to really be helpful for prostate. Stuart, did you have any more, Eric?
Nope. Nope, that was it.
What I have one question, something that a friend told us about, and it's really unconventional. But y'all may have heard of this. It's called the Joe Tippin protocol. Y'all have heard of that? And what is your thought on that? Because I don't know much about it.
Well, the anti-wormers did kill the worm in RFK's brain and cured his brain worms. There's no evidence that it will work. Those medications are very effective against an isolated cell line. If you had a school with 10,000 people and everyone was an exact identical copy of the next one, and you did something and it killed one cell, then it may kill all the other cells. If you have a school where you have 10,000 different people and you treat one of them, the other people may be glad that that one is gone and they go to town and grow faster. The problem is with these treatments is that they've only been tested in a lab. When you do a test against a cell line, you're killing just one type of cell and you don't know how the other cells, the remaining cancer cells, are going to respond. And you may actually be giving more aggressive cells a boost by doing that. But there's absolutely no evidence to say that this protocol works. I did come across one study about 2 years ago. I haven't been able to find it since, where they actually did a comparison and randomized trial, and there was no benefit to it. So there's a lot of hype, and why people are willing to ignore treatments that have been shown effective, treatments where you bring the leading urologists together across the country to have an input and a voice on what works. And someone on the internet says, well, we're going to use a dewormer. And there's no evidence to show that it's beneficial. I don't know why that holds on and why he has such a voice.
Yeah. I'll just add my 2 cents. Dr. Mark was very polite, but fenbendazole is a bunch of crap. And you can do it if you like, but it's not going to help with your prostate cancer. Stuart, you have your hand up. We can't hear you, but your microphone is on. Your microphone's on, and we can't hear you. No wonder you've been so silent this whole time.
How about now?
Yes, we can hear you now.
James, I hear you talking about having spent a tremendous amount of time investigating treatment options. And quite frankly, I think you're putting the cart before the horse, since it doesn't sound like you really have a good doctor that you can trust to guide you. And I would really urge you to focus on getting to one of these centers and getting to one of these good doctors that you feel like you can team up with and feel confident in, because then they're going to help guide you in terms of the treatment decisions. And, different doctors will go in slightly different ways. I have a radiation oncologist in New York who, he uses MRI. Rick's got had a radiation oncologist in San Francisco who says, I can do with SBRT as well as, any other machine. And so I would place my faith more at first in the doctor and then make a decision about technology, as opposed to focusing first on the treatment options. I think you're wasting a tremendous amount of your time and just going to confuse yourself more with proton versus photon and all this other stuff. The doctor's the one who's going to make or break your treatment.
Okay. Yeah. Good advice. Good advice.
Before we sign off here tonight, I want to particularly, well, actually, it's not me, but I've been asked to thank Jose and Eric for setting up Heal last week. And my friend left, but if you want to Google Solo Arts Heal and AnCan, Andrew, our mascot, was on with Alexa, who did an amazing job, interviewing Andrew and putting on a show for us. So thank you guys. Andrew really was appreciative.
Mark,
Yes.
you are his companion, though. Andrew is the main guy. You're just his companion. So
Translator, and I helped with the closed captioning.
Mark, before we hang up, would you please, I just sent you a note. I have to delegate here. Would you please reach out to Howard Walensky and just ask him if he can recommend a urologist who is pro-active surveillance, early active surveillance at either UTSA or UTSW.
Okay, and that we have Emily and James' email.
Yes, we do.
I don't.
Yeah,
Oh.
and Rick, listen, I'm not opposed to going to Houston. Okay, all right. I mean, if I have to go there, I'll do it. If it's
Okay,
the best.
well, let's just see what. Can you just put your? I know we have it. It's because we put you on the database, but could you just put your email? Save me either to everybody or just to Dr. Mark, and then we'll check with Howard if there's anybody he likes that he's worked with for active surveillance at UTSA or UTSW. I just looked, by the way. I went to both. I've got both their sites here. I don't recognize any of the names at either UTSA or UTSW, but that doesn't mean a whole heck of a lot because I don't know the urologists.
But I think that while your docs were right in telling you very few die from prostate cancer, and the fact that you had a good PET scan right off the bat is supportive of that. Dealing with this efficiently without stress and without overreacting and doing surgery if it's not necessary is not a good idea. And sometimes you may need to travel. I was living in Atlanta and exhausted all the people there. I got opinions from Chicago, from Boston, before I came out to Los Angeles and met with Dr. Scholes and Dr. Keyshawn and some of the other people at UCLA. So you're worth it. And the way your doc has treated you so far would not be the way I would want to see someone who I cared about treated. And I think you need to not be afraid to travel if that's what you need to do to get the right care.
Right. I mean, the only reason that I suggest that you, I suggested MD Anderson is because I know that Hugh's very, very happy with his care there. He switched to MD Anderson. They've done a great job by him. He's still on active surveillance. So he has a really solid urologic oncologist that we can send you to there. We got a couple of other people. All of the people that I've worked with in Dallas and also in San Antonio have more advanced cancer. But we'll reach out to Howard Walensky and we'll see if he's got any names. We'll come up with somebody. There's got to be people there for you if you prefer, if it's easy for you to go to Dallas or to San Antonio.
Yeah, I put both Emily and my email address.
Got it. Yeah.
Okay.
Yeah. How Dr. Mark's on it. All right, guys, we've run well over. This has taken us longer than even our recurrent, our high-risk recurrent advanced group. So
Good job, Mark.
great
And
job,
Greg,
Mark.
everybody.
Yeah, very good. Thanks, guys. Do appreciate it.
Yeah.
Thanks a lot.
Okay, well, we will see you in a little bit. Have if you are traveling for Easter break with kids, do well. Enjoy.
Dr. Mark, hold on. Dr. Mark, hold on 1 second. So we're done. So, you
turn off the.
People can leave if you want to leave. You don't have to leave.